Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through Med-Surg or adult health, nephrology or renal, whatever you want to call it. And we're not going to be including GU, which would be urinary, which some schools will include in this. So we're going to have a separate lecture for that. So let's go ahead and jump right into nephrology. Let's start with understanding a little bit of the basic anatomy and physiology. The kidneys, we have two of them. They're on either side of our body. They're in the retroperitoneal space, so behind the peritoneum. They're enclosed in the renal capsule. Now let's move on a little bit further. The parenchyma includes the cortex, the pyramids, and the medulla. On the image that you can see on your screen, the cortex is the outside part of the kidney, and in there is where the parenchyma starts, and that is where the nephron starts. And then it extends, the tubules of the nephron extend down into the actual middle of the kidney, what we call the pyramids and the medulla. So again, the glomerular and the tubules, which make up the nephron, the glomerular is up in the cortex, and the tubules extend down into the middle, what we call the pyramids and the medulla, and all of that is included in the parenchyma. Let's move on. What is the flow of fluids throughout the nephron? So our blood, regular whole blood, enters the glomerulus, that's in the renal cortex, and then once it enters there, it continues on down a pathway. It goes to Bowman's capsule, it goes to the proximal convoluted tubule, to the loop of Henle, also called the nephron loop, to the distal convoluted tubule, to the collecting duct, and then out into the bladder. What's happening along this pathway? Well, along this whole pathway, and it depends how deep you have to actually know this for your school. I'll let your school go further into exactly if they want you to know what electrolytes get pushed out and pulled out in each section, but I'm going to give it very broadly that throughout this process, as our blood enters the glomerulus, on the pathway all the way to the bladder, during that process, as it's traveling through the nephron, the body is pulling back in, so out of the nephron, reabsorbing is what it's called. The body is reabsorbing from the nephron. It's reabsorbing the blood cells, the plasma, the sodium, the potassium, whatever it wants to hold on to. And whatever it doesn't want to hold on to stays in the nephron. And by the time it gets out of the nephron towards the bladder, now it's called urine. So that's the process of what it does. That's how it goes through. We know this is relevant for a lot of medications because a lot of medications are excreted through the kidneys, and we'll talk more about that. But that's the basic process of what the kidneys do, what the different units in the kidney are, and how they function. Let's talk a few more nephrology concepts. First of all, ADH, antidiuretic hormone, is a hormone that works on the kidneys, and it pulls water out of the nephron back into the body. So it orders the body to reabsorb water back into central circulation. It makes us hold on to more water. There are two endocrine diseases that you'll learn about related to ADH. One is diabetes insipidus, one is SIADH related to this, but just to understand the basics of what that is. Next, we have another hormone. This one's aldosterone. Aldosterone promotes sodium reabsorption and potassium excretion in the distal tubule. Now, again, aldosterone is another one that depends how deep your school wants to go into this, but just let me give you the highlights. Aldosterone reabsorbs sodium, and because it reabsorbs sodium, it pulls water. And again, when we say reabsorbed, it means back into the body, that it stays in the body, that we hold on to it, that it doesn't go out into the urine. Because it holds on to sodium, and that means it holds on to fluid, it is an antidiuretic. It makes you hold on to fluid. Okay, because there is going to be some times where we want to block aldosterone in order to get rid of fluid, but aldosterone would naturally hold on to fluid. Next, what else are the kidneys responsible for? The kidneys regulate our pH by reabsorbing bicarbonate and excreting hydrogen ions. They can also do a lot more things in relation to getting the pH balance. If you remember from basic anatomy and physiology, there are three mechanisms that control our pH. There's the bicarbonate acid, there's the acid bicarbonate buffer system, there's the lungs, and then there's the kidneys. The kidneys are the end-all be-all. They get our pH exactly the way we want it by excreting the exact number of hydrogen ions, and by holding on or generating the exact number of bicarbonate ions in order to have a perfectly balanced pH. So if we don't have the kidneys working properly, it can mess up our pH. Next, the kidneys also secrete erythropoietin. Erythropoietin is what stimulates red blood cell production in our bone marrow. So if a patient's having kidney disease, then they may end up anemic because they're not getting that stimulation to produce red blood cells. Next, the kidneys also secrete renin. Renin is the key component in the renin-angiotensin-aldosterone system. Let me give you the 2-minute review. The renin-angiotensin-aldosterone system is run by the kidneys, and it exists in order to make sure that our blood pressure doesn't get too low And more specifically, it's run by the kidneys to make sure the kidneys themselves get enough perfusion. So the kidneys have access to run this renin-angiotensin-aldosterone system. So how does it work? Whenever the kidney sense that the blood pressure is dropping, or at least it may not even be dropping, but it's not to their satisfaction. The kidneys say, I want a higher blood pressure. The kidneys release renin whenever they want to. Whenever they want to bring up the blood pressure, whenever they want to increase the blood flow to themselves, which also increases the blood pressure, they're going to release renin. What's renin going to do? Well, it's going to go through a whole bunch of steps. It's going to activate, mix with angiotensinogen and turn into angiotensin 1, which turns into angiotensin 2. And then it's going to get two end results. What are those two end results? The major end result of that is vasoconstriction. It makes the vessel smaller. And by now, hopefully you understand that vasoconstriction is going to bring up your blood pressure, which is what the kidneys want. The second thing it does is it blocks aldosterone. Again, we said aldosterone, or I'm sorry, it stimulates the release of aldosterone. Aldosterone, we just said, makes us hold on to fluid, which again increases our blood pressure, which again increases blood flow to the kidneys, which is what they want. So one more time, when the kidneys want to increase the perfusion to themselves, which also increases the blood pressure, they will release renin. Renin will cause vasoconstriction, and it will cause the body to hold on to more fluid. But much more significantly is the vasoconstriction part of it. That's where it really gets its increase in blood pressure. Next, the kidneys maintain regulation of fluid and electrolytes. That one's pretty obvious. The kidneys go ahead and they hold on to fluid, or they get rid of fluid, whatever they want, in order to maintain a perfect fluid balance. And same thing with every electrolyte. The kidneys are also responsible for synthesizing vitamin D. So again, a patient in renal failure may end up with vitamin D deficiency. And finally, we already talked about this, kidneys have a role in the excretion of a majority of medications, and therefore it's extremely important to recognize that if a patient does have a kidney issue, especially end-stage renal disease, that they may not be able to excrete medications properly, and they may need their medication doses adjusted. Let's go ahead and move on to different nephrology assessments and diagnostics. First of all, any patient who's a nephrology patient is going to need to have their fluid monitored. How do we do that? We do that by checking their skin turgor, checking their edema. Obviously, we know poor skin turgor, which is called tenting, is a sign of hypovolemia. Edema, if they have a lot of extra fluid, that could be a sign of hypervolemia, as well as a bunch of diseases. JVD, again, this is a little bit more specific to heart failure, but again, it does show a sign of fluid overload. Blood pressure, if that gets too low, that could be a sign of low volume. Input and output, that's probably the most commonly used method of tracking a patient's long-term, meaning over hours and days, of how their volume status is doing is by checking how much urine they're putting out. Mucous membranes, I'm sure most of you remember that dry mucous membranes is part of your key assessments to check for dehydration. And lung sounds are very much tested on in nursing school, though not as practical to use to assess for fluid overload. But yes, if you do hear crackles in the lungs, that could be a sign of fluid overload. Next, normal urine output in adults is 0.5 to 1 milliliters per kilogram per hour. In most adults, roughly over 24 hours, they're going to put out somewhere around 1,000 to 1,500. I've seen most books use that number, 1,000 to 1,500 mLs per day, per 24-hour period. That's the rough number. When you get roughly below 0.5 ml per kilogram per hour is where we consider you oliguric. Again, if you're using the full day's number, most textbooks I reviewed are going to show something around under 500 or under 400 as that number for when, meaning under 400 or 500 mLs put out in a 24-hour period. That's where the patient's becoming oliguric. Next, let's go through some nephrology-specific labs. We have urine-specific gravity. This is obviously tested on a urinalysis, and a normal range is listed over here. If a patient has an elevated urine-specific gravity, that means the urine is very concentrated, which is a sign of dehydration. Next, we have serum creatinine. Normal range is listed here. Now, a creatinine is one of the things that the kidneys gets rid of. So if we see that number coming up, we know that the kidneys are not doing as well of a job. Same thing with BUN, blood urea nitrogen. Again, that's something that the kidneys are getting rid of. So if we see that level elevated, we know that the body is not getting the kidneys are not getting rid of it that well, so that could be a problem with the kidneys. Now, both of these numbers, the creatinine and the BUN, these are almost always used universally together. What is their creatinine and BUN is very commonly said in nephrology terms. Both of these can also be elevated in dehydration, because when the kidneys aren't getting their proper perfusion, that can cause the creatinine to go up, that can cause the BUN to be falsely elevated because of dehydration. Same thing with the next lab, serum sodium. This wouldn't normally be considered a nephrology lab. Let me explain to you why it is. Nephrology has to do with fluid and electrolyte imbalance very extensively, because that's part of a big role of what the kidneys do. So when the kidneys are excreting, when we're checking a fluid balance, if a patient has a very high sodium level, it may not be that they took in a bunch of sodium. In fact, that's extremely rare. In most cases, when a patient has a very high sodium level, It means that they are simply dehydrated. Let me explain. If I have a gallon of water and a cup of salt, and the two of them together would equal a normal sodium level. A gallon of water and a cup of salt, I have a normal sodium level. Now, if I'm going to have a high sodium level, either I can have a ton more salt, or if I spill out half of this gallon of water, and now I'm left with a half a gallon of water and the same cup of salt, even though my salt volume stayed the same, because my water level dropped, my sodium is going to come up really high because it's now much more concentrated. Same thing here, a serum sodium can be used to assess for dehydration because the most common reason why a patient would have hypernatremia is for dehydration, and that's why I'm talking about it in nephrology. Serum osmolality, this is the blood version of the urine-specific gravity. It checks to see, again, how concentrated the blood is. And over here, if we have a high serum osmolality, again, that could be a sign of dehydration. Finally, we have the GFR, the glomerular filtration rate. Normal range is 90 to 120 mLs per minute. Believe it or not, your kidneys are amazing. They filter out 90 to 120 mLs per minute. And we get this GFR. It's part of a standard set of labs that we get on all our patients, or many of our patients, certainly all of our nephrology patients. But the best way, in case you're ever tested on this, the best way to get a GFR is based on a test called the creatinine clearance test. I just put this in there because I've seen this on a few nursing RN test bank questions. Let's keep going. We have a urinalysis. A urinalysis is going to be one of the most common labs that we do in nephrology, and we do them all the time in general. The nursing instructions would be to tell the patient to wash the perineum before going pee. They should collect it midstream, meaning they should start peeing, then hold it for a second, and then put the cup there to catch midstream. And that's called a clean catch, where we clean the perineum, where the patient starts peeing first, and then we tell them to start collecting it midstream. And ideally, if we want to get the richest, so to speak, the most useful diagnostic urine would be the first urine of the morning. Many of you may know for pregnancy tests, we always tell women to go ahead and check that first thing in the morning is more reliable and more likely to come up positive earlier than a later urine test in the day. Next, a few characteristics of a urinalysis. Cloudy or reddish urine may indicate infection or hematuria. Proteinuria is a sign of glomerular dysfunction. We'll talk a ton about that. Proteinuria is not a normal finding. You shouldn't see that, and that's almost always the cause of a problem. And nitrates and leukocytes esterates are indicators of a UTI. Again, these are all different findings that you could find on a UA, which is a super common, super cheap, easy test that we do all the time. Next diagnostic we have is a renal ultrasound. There's a lot more that goes into this, but I'm just giving you the broad overview over here. These are used to evaluate kidney size, kidney structure, and to detect certain abnormalities like hydronephrosis, cysts if the patient has polycystic kidney disease, PKD, or if they have tumors or things like that. Next, we have a KUB. You may have heard of a KUB. If you're wondering what that is, it stands for kidneys, ureter, bladder, and it's an X-ray. There's a chest X-ray. There's a KUB X-ray. A KUB X-ray is kidneys, ureter, or bladder. It's used to detect kidney stones. It's used for obstruction, other abnormalities. We don't use it a whole ton because the big benefit this has is that it's super cheap, easy, quick, non-invasive. The downside it has that for pretty much all of these things, we almost always have a better test, whether it's ultrasound or a CT or a biopsy. We almost always have a more conclusive, more useful, more accurate testing to use. But we do still sometimes use this, sometimes just to rule out other causes. If we expect everything to be okay, we just want to make sure we can do this. Let's get into some more nephrology-specific context. Let's talk about hemodialysis first. And towards the end of this lecture, we're going to get into all the different diseases in just a few minutes. So hemodialysis, which is often abbreviated HD, what does it do? It filters waste product, excess fluid, and electrolytes from your blood, which is exactly what the kidneys do. There's the AEIOU criteria for when we would do an emergent dialysis. Obviously, we do dialysis for all patients that have ESRD, which we're going to talk about in a little bit, end-stage renal disease, where their kidneys are essentially shut down and done and retired. Then we put the patients on chronic dialysis. But over here, the AEIOU criteria is when we would do emergency dialysis for a critical patient. And this would be for A is acidosis, E is severe electrolyte imbalance. This is very uncommon and would be really severe for us to do this. For an ingestion or intoxication, something like an aspirin overdose, if it's really severe and life-threatening, they would get dialysis. Fluid overload, again, this is where we have no other way of getting the fluid off, which is, again, relatively uncommon other than in a nephrology patient. And uremia, where we have a really high BUN showing that the kidneys are not getting rid of that urine, basically the uremia, essentially the urea that's in the blood. Next, we have, when we talk about hemodialysis, we have to talk about access, because these patients are generally not just going to come in every single Monday, Wednesday, Friday, or Tuesday, Sunday, or Tuesday, Thursday, Saturday, and just come in and get an IV started for this. We generally need really large bore access. We need access 3 times a week. This is extremely difficult for a patient to undergo if they're getting regular traditional IV sticks 3 times a week with this really large bore IV. So because of that, we do use these other access types. So we have arterial venous fistula, AV fistula. This is the #1 most recommended use. And this is created, this fistula, it's done in the arms, and it's done by one arm, I should say. It's not in an arm. It's done by creating a connection between an artery and a vein. Now, this takes several weeks until after the procedure, until it's actually usable. And then from that point forward, that's what the patient uses for their dialysis treatment 3 times a week or whatever their indication is. This is the preferred method because it has lower risk of infection, it has lower clotting risks, and other benefits as well. The next best choice is an AV graft. This is where they take a tube. Again, this is a surgical procedure. They take a tube and they put it and they make a connection between the artery and the vein, again, in one of the arms, and this becomes an AV graft. This is not as preferred. This would be a backup option, and because it has a higher risk of complications than simply making a fistula. Not simple. I don't know how to do it. I'm not a surgeon, but you get the idea. And then finally, the last choice would be a central venous line, which is basically a very or a semi-permanent catheter that can be used for several weeks or even longer. And a central venous line would be used temporarily until we get that AV fistula, that AV graft. Again, the AV fistula takes several weeks until the patient can actually use that access for dialysis. Same thing with an AV graft. The central venous line, that's the famous central line that we talk about. We talk about CLABSI, or central line associated bloodstream infection, which is a major issue in healthcare. When we talk about all the risks of sterile procedures for that, the central venous line is the thing that has a big no-no for high risk of infection and clots and other issues. So that's going to be our temporary only measure. When you're assessing these different access, specifically the AV fistula, the AV graft, we are going to check for a thrill or a bruit. These are 2 commonly tested on terms in nursing school of how we assess the patency of these access methods. A thrill is where you touch the location of the access and you should feel the blood vibrating as it goes through it. Or bruit is where you put your stethoscope on there and you hear the blood whooshing through that area. Dialysis patients that have a fistula or graft cannot get blood pressures taken in that arm. Next, when you are caring for a patient that is getting hemodialysis, do keep in mind that the dialysis may clear out any medications that you give. So very often the medications will say to administer after dialysis. Also, we would generally not want to give anything that lowers a patient's blood pressure before dialysis, because their blood pressure will naturally drop with dialysis. A, because we're pulling blood out. B, because we're pulling a ton of fluid permanently off that patient. So we generally don't give an antihypertensive, a blood pressure lowering medication before dialysis. Again, those are safety considerations to have. In addition to hemodialysis, which is what we talk about when we're talking about like DaVita or Fresenius or these massive dialysis clinics that unfortunately so many patients go to, but we do have other options. 2 of them I'm going to list over here. Peritoneal dialysis. There's actually a ton to know about this, but some books really didn't cover it a lot, so I don't want to go too deep into it, depending on your nursing school, what they're going to get into, so I'm going to leave it up to them. Just to give you the broad overview, peritoneal dialysis, it uses the peritoneum, the abdominal area, as a natural filter. So the dialysis solution is infused into the abdominal cavity, and then it absorbs all the waste products and the excess fluid, and then when it's pulled out, you sort of went through dialysis. This is another option. Again, there's a ton to learn about this if your school goes into this, about when this is used, what are the indications, how exactly it works, the different fluids, all of that. I'm going to stay away from that because I've seen some schools just really brush over it, so I'm going to do that same. Next, we have CRRT, which is continuous renal replacement therapy. This is a slower, continuous dialysis, and this is very often done in the ICU. ICU patients can rarely tolerate, or critical ICU patients can rarely tolerate hemodialysis. So in that case, we'll almost always do CRRT, which is basically a much slower version of continuous dialysis. And the big benefit is we're not causing this massive electrolyte disturbance. We're not massively shifting fluids. We're not massively depleting a bunch of fluid out of the body in order to filter it at the same time, because they wouldn't tolerate that well. But we do it on a very slow 24-hour process. So basically, we're doing exactly what the hemodialysis machine does in 2 to 4 or 5 hours, or even less. And now we're doing it over 24 hours. So it's much more conducive to an unstable patient. Next, let's talk real briefly about kidney transplant. Kidney transplant is the only treatment for ESRD other than dialysis. The short-term issues with kidney transplant are the patients can have graft rejection, they can have infection, or they can have delayed graft function. The long-term issues are going to be that they may develop infections, they may develop cancer, and they may have medication-related complications. This is talking about the medications this is talking about the side effect of the medications they would have to take due to being a kidney transplant patient, because they may be on long-term, let's say, steroids for immunosuppression or things like that. And because they're going to be on some sort of immunosuppressant, they're at risk of infection. If they're on steroids, it's going to be risk of osteoporosis or diabetes or high blood pressure. So those are the more long-term complications of a kidney transplant. But again, we don't have any other cure. We just manage it with dialysis until a kidney transplant is an option. Some patients with kidney transplant are going to require dietary modifications. First of all, we're going to have to limit their, we're going to have to limit their protein intake. Most patients that are have kidney issues or on a kidney diet, if you'll see that ordered in the hospital, that's going to be low to moderate protein. It's never going to be a heavy protein diet, depending what the condition is and how severe it is, how much we're going to limit their protein. But protein tremendously increases the work of the kidneys. We may also make it low sodium diet because, again, if the body's holding on to sodium, or if the kidneys are not doing a good job getting rid of sodium, then that's going to cause a fluid and a sodium imbalance. So we would want to limit that. Potassium, phosphorus, also, again, these are all things that if the patient is taking too much of it, it increases the work of the kidneys. It could build up in the patient's system because the kidneys are not doing as well of a job. So those can all become issues. Those would all be dietary considerations. I think in what I looked at, the nursing test banks, the protein and the sodium were the two that were tested on the most. With potassium coming in third. Next, in older adults, the GFR typically declines with age. This is perfectly normal. And we're going to talk in a few minutes about what a normal GFR is when we get down to CKD that you can see at the bottom of your screen right now. But when we talk about GFR, it is normal for it to go down with age. Normal is going to be 90 to 120, or a really healthy patient might have it even a little higher. But but with age, it will naturally come down. But let's talk about that for a little bit more. This leads to elevation in creatinine. And it can lead to increased risk of dehydration and other issues as the GFR comes down. And we already talked about it results in the inability or the reduced ability of the body to get rid of certain medications. Speaking of medications, really quick, this is super common on nephrology exams, is what are the nephrotoxic drugs? There's at least 50 of them. But the most common ones that I've seen tested on are NSAIDs. Know your NSAIDs because those are all nephrotoxic. Aminoglycosides, or some text banks just in general say antibiotics because there's a bunch more that are known to be nephrotoxic, but aminoglycosides is by far the most commonly tested on one that I've seen. And then contrast dye is also a really common nephrotoxic drug. Now, I do want to tell you, anytime you give a patient, both in real life and for nursing school exams, anytime a patient is going to be getting a CT with contrast dye, you are always going to be checking a BUN and creatinine beforehand, because if the creatinine is elevated over that 1.2, almost always you're going to have to see about whether we're still going to give that contrast dye or not. Now let's move on to the actual diseases, and then we'll wrap up this lecture. So patho and nursing practice for all the nephrology diseases. We're going to start with acute kidney injury. So AKI, acute kidney injury, is a sudden decline in kidney function, typically defined as a decrease in the GFR, or you can see it as an increase in the BUN and creatinine over a short period, meaning it happens quickly over a few hours or a few days. Now, there are three ways that this is broken down. AKI is broken down into pre-renal, intra-renal, and post-renal. Pre-renal means it has nothing to do with the kidneys. It's some situation outside the kidneys. Almost always, this is that the patient's in shock, whether it's due to severe dehydration or trauma or whatever it is. If the kidneys are not getting well perfused, they're going to go into pre-renal AKI. What does that mean? Because they're not getting well perfused, just like a heart attack happens when the heart's not getting well perfused. If the kidneys are not getting well perfused, they can end up in pre-renal AKI. The GFR goes down, the BUN creatinine go up, the kidneys can head towards failure. So that's due to decreased perfusion. We'll talk about that in just a minute about how to fix it. Next, we have intrarenal. This is where there is a problem with the actual kidneys. This could be lots of different causes. This could be because of nephrotoxic medication. It could be from PKD or something like that. And then finally, we have post-renal. This is due to an obstruction in the urinary tract. And over there, it could be something like a stone. It could be something like a malignancy, a tumor that, again, it's outside the kidneys, but it's past the kidneys along the urinary tract. So those are the three causes of AKI. The most common one that we usually deal with is going to be, especially since this is an acute situation, is usually going to be pre-renal, because almost every patient that goes into shock is going to end up in AKI. The presentation of this is going to be oliguria or anuria, that they're going to have low urine output or no urine output. If it's really severe, they're going to have edema, which is pretty uncommon. They'll have edema, they'll have fatigue, confusion, nausea, vomiting, shortness of breathing. All of those are the signs and symptoms of AKI. This is generally diagnosed based on presentation and renal labs. And again, most of the time with AKI, we see it coming. We know that there's an underlying condition that makes the patient at risk for developing AKI, and we're hopefully ahead of the curve in monitoring this. The management of AKI is going to be, first of all, for nursing purposes, we're going to monitor their input and output. We're going to give them fluids. We're going to monitor their renal labs, and we're going to monitor electrolytes. Again, if the kidneys are not working, the electrolytes can get skewed, which can mess everything up and cause heart attacks and worse. Next, we have the management for specifically each type of AKI. Pre-renal AKI is a problem with the patient's in shock, so we're going to fix the problem of the patient being in shock. We're going to give them lots of fluids. The intrinsic AKI, this is where the patient had, or intrarenal AKI, depending which one you look. I should have kept it uniform, calling it intrarenal, but this is another term you'll see. The intrarenal or intrinsic AKI is going to be addressed by dealing with the underlying cause. If it's a nephrotoxic medication, then let's stop that, or whatever the cause may be. Post-renal AKI is done by relieving the obstruction, again, however that may be. AKI generally progresses from an oliguric phase where we see that elevation in the BUN creatinine and that drop in the GFR, that drop in urine output. Once the patient starts to recover, for example, I've seen in some test banks where the students get asked, what would a sudden increase in the urine output in a patient AKI indicate? That would be a good thing. That would show that the patient's entering the diuretic phase. If the patient is in pre-renal AKI, which is generally the most common, pre-renal AKI patients, that shows that the hemodynamic status has suddenly improved, or not suddenly, but it has improved, and now the kidneys are able to function again and put out urine again, and that's a good thing. And then finally, that ends up with recovery. Next, we have CKD, or chronic kidney disease. So this is a big one that we're going to talk about. The pathophysiology is a progressive and irreversible decline in kidney function due to chronic damage to the nephron. Remember, the nephron is that actual unit that does the filtration, that does the actual work of the kidneys. It is classified in 5 stages based on glomerular filtration rate. Again, 90 to 120 is where we consider normal. And then we have stage 1, 2, 3, 4. We have stage 90 to 120. So then we drop down from 90 to 60 is going to be stage 1. From 60 to 30 is going to be stage 2. From 30 to 15 is going to be stage 3. And then ESRD would be stage 4, and that would be 15 or less. I will tell you, I specifically did not put that in here because I have seen 1 or 2 textbooks that use slightly different numbers, but I'm going to go with the ones that I've seen in the most majority of textbook, which is going to be that 90 to 120 being the normal or the borderline, again, the normal range. And then we'll start to get below normal range. We'll start to get below 90. Again, a patient can have a normal drop in their GFR as they age. That's normal. It doesn't mean they have CKD. But again, CKD, 90 to 120 is normal. 60 to 90 is where we start to get into problems. 30 to 60 is really bad problems. And when we get under 30 is where we're heading towards ESRD, or I've seen some places actually consider that ESRD already. But below 15, GFR is always going to be is always going to be ESRD, where the patient has to be on dialysis. Their kidneys are no longer functioning. Common cause of CKD is diabetes, hypertension, AKI, and polycystic kidney disease, which we'll talk about in a few minutes. I'm going to tell you by far the number 1 most common cause of CKD is diabetes. Tell your patients to manage their diabetes. We'll talk about that when we get to endocrine. The presentation, patients will typically be asymptomatic for a long period of time. Once they do become symptomatic, they can become fatigued, anemic, hypertension, edema, pruritus. That's where, because the kidneys are not properly filtering out uric crystals, that comes through to the skin, which can cause that pruritus, as well as electrolyte imbalances because the kidneys are not doing their job. CKD is officially diagnosed by having a GFR under 90 for at least 3 months consecutively. The management is to slow the progression of the disease. We don't have a cure. Again, if CKD always ends up at ESRD, if the patient lives long enough, it ends up at ESRD, and in that case, the patient is going to end up on dialysis. Our goal is to make sure that doesn't happen, to slow the progression so much that they never actually get there. And we do that by managing the diabetes most of the time, otherwise, whatever the underlying cause is. The only definitive treatment for CKD, once they get to ESRD, to end-stage renal disease, which is that last section, which is where the GFR is below 15 or below 30, depending on the guideline you're looking at, that's where the patient has to be on dialysis and can only be treated with a kidney transplant. There's a whole lot that goes into talk about kidney transplants. I don't think nursing schools are going to get into the whole ethics of it and understanding the transplant boards and the transplant process and committees and all of that, so I'm going to skip all of it. Next, for these patients, we are going to make sure they're taking their medications. We're going to make sure they're on their fluid and diet restrictions. That's going to be the low protein for sure, the low sodium, things like that. And if they're on dialysis, we're going to facilitate them, making sure that they're getting the dialysis that they need. We're going to keep a close eye on complications, especially once they get to that ESRD, to that dialysis stage of checking for fluid and electrolyte imbalances, such as hyperkalemia, hypermagnesemia, hyperphosphatemia, and hypocalcemia. Notice which ones are hypo and hyper, because I've seen this as common test questions in nursing banks about dialysis. Next, let's move on to pyelonephritis. Pyelonephritis is an upper respiratory tract infection. So a UTI, which is commonly taught as part of nephrology, even though that's really urology and we're going to have it separately, but a UTI is very common, very well known. It causes dysuria and frequency, things like that. Pyelonephritis is where the UTI, the infection, has now come up to the upper urinary tract, getting up to the kidneys. So over here, it's no longer focused on the urinary tract, it's come up into the renal pelvis and into the kidneys themselves. And that becomes pyelonephritis. The presentation is going to be, in addition to UTI symptoms, because they still have a UTI, in addition to the UTI symptoms, they're going to have fever and chills and flank pain, CVA tenderness. If you don't know what that is, it stands for costovertebral angle. And that's, if you know where the kidneys are, you take it, you just hit it like that. And if the patient jumps disproportionately from that pain, then that is CVA tenderness, costovertebral angle, very commonly tested on in terms of pyelonephritis. But again, it's a UTI plus. It's a UTI plus the fever, the chills, the flank pain, and CVA tenderness. We diagnose this by lab work, such as a white blood cell count, the UA, and the urine culture. The management is going to be antibiotics. Almost always the first-line drug in every guideline that I've reviewed is going to be fluoroquinolone, such as ciprofloxacin, to treat this. We're also going to treat this patient with fluids. You'll notice pretty much all kidney diseases, other than final, where the kidneys are no longer working, but all of them are treated with some sort of fluids, as well as pain management. Excuse me. Moving on, nephrolithiasis, which is renal calculi, also known as kidney stones. The pathophysiology here is the crystals aggregate and they form stones. The most common types are calcium oxalate, uric acid, struvite, and cysteine stones. I've seen a few textbooks actually break them down into 4 different diagnoses. I'm not going to do that. We're going to lump them all together. I don't think in nursing school, I don't think the NCLEX would get too deep into that. The stones may obstruct urine flow, leading to pain and possibly kidney damage. The classic presentation of this is severe colicky flank pain. These patients, when you see it, they can't sit still. They're rolling on the floor. They're rolling in bed. They keep repositioning. They can't get comfortable because of that pain. That's what that colicky flank pain means. Almost always this comes with nausea and vomiting. Very often it has hematuria, dysuria, and urgency. Those last 3 also familiar from UTI discussion. Next, we have this is diagnosed by a non-contrast abdominal pelvis CT, or you can do it by a renal ultrasound or a KUB. By far, the most common is the non-contrast abdominal pelvis CT. The big issue where we stay away from that is in a pregnant female. The management of this disease is going to be pain management, ambulation. The more a patient is active and moving, the more they'll be able to, the studies have shown that helps pass the stone, and obviously increasing hydration. In the hospital, since we're not big into ambulation, at least not in the ER, which is where these patients are usually treated, we focus on the pain management and increased hydration, and then we go ahead and we encourage them at home to continue pain management, continue fluids, and to ambulate as much as possible. Next, now this is probably a little bit beyond what you need to know in nursing school, but just for your information, the stones, we do classify them to one of 3 sizes based on the CAT scan. And if it's less than 5 millimeters, which most of them are, they typically don't need any intervention. If we have bigger stones between 5 and 10, again, I wouldn't focus on this. It's a little bit beyond, but just good information to have since this is so common. Those patients will often given an alpha blocker. And if a stone is greater than 10, then those patients get referred to urology. You will see plenty of providers that even once it gets above 5 or 6, they're already sending them to urology. The interventions that urology might do is cystoscopy. Cystoscopy is where we put a special tube up the urethra, and we can use this for diagnosis purposes. We can use it to get to help these stones pass. We use it for a few different things. Next, we have lithotripsy. This is very well known as those ultrasound shock waves that we use to shock, to break up transdermally. We don't go into the body. It's a non-invasive procedure, but we use those waves to break up the stone. Or we have lithotomy, which is surgery where we go in and get out those stones. The stones may obstruct urine flow, leading to pain and possible kidney damage. Again, this would be the classic example of that post-renal AKI. Ensure that urine straining is happening both for you or if the patient's going home. We often want to educate them that they should be doing that to strain the urine to collect their stones, especially in the hospital setting, because very often we're going to send those stones to the lab to get some diagnostics on it, because if we can figure out exactly what type of stone it is, maybe we'll have some more customized dietary recommendations, which leads to our next section on what, or our next bullet point on what the patient should do to avoid this becoming a regular problem for them. Because unfortunately, a lot of times when patients get kidney stones, they get them more than once. And we want to teach them the dietary risk factors that they can avoid, that they should be employing to avoid them getting it again. Next, we have glomerular nephritis. Pathophysiology over here is inflammation and damage of the glomeruli, leading to their inability to filter blood properly. The presentation over here is going to be oliguria. Again, that's pretty common in nephrology issues, along with fatigue, hypertension, and cola-colored urine. If you see that on a test bank, it's almost always talking about glomerular nephritis. I will tell you, some textbooks I've seen lump this and the next one, the nephrotic syndrome, into one, in which case that cola, I've seen the correct answer for that cola question as either glomerular nephritis, that was more common, or nephrotic syndrome, which we'll talk about in just a minute. So this disease, glomerular nephritis, the inflammation of the glomeruli, is diagnosed by urinalysis, by labs, but it is confirmed by kidney biopsy. That is the standard of what we do, and that does guide our treatment once we get the results of that kidney biopsy. The management over here, it is an infection, so we do give antibiotics. Obviously, we're going to culture it and see what the infection is, and we're going to provide supportive care. If this is not caused by an infection, it would almost always be caused by an autoimmune disease, most commonly lupus, or there are some other more rare issues that can be causing this. If this is not treated, this can lead to CKD. Next, we have nephrotic syndrome. Like I said, some books are putting nephrotic syndrome as a subclass of glomerular nephritis. It is also the problem with the glomerular. And over here, the pathophysiology is that damage to the glomerular filtration barrier leads to abnormal permeability. And the classic sign, or the classic definition of nephrotic syndrome, is massive loss of protein in the urine. So normal urine is going to have protein loss of less than 150 milligrams in a 24-hour period. You're going to have 20 times that. You're going to have 3.5 grams per day is going to be diagnostic for proteinuria. But let's not jump ahead. The presentation is going to be proteinuria. Again, we can easily catch that on a UA, on a urinalysis. The patients will have foamy urine. Anytime you see foamy urine, unless it's to do with the way the patient was peeing or the object that they were peeing into, that's a sign of proteinuria. Don't be diagnosing based off that, just for nursing school purposes, recognize that. Also, periorbital, around the eyes, and peripheral, the legs, edema is also associated with nephrotic syndrome. I also seen ascites and central edema as being associated with nephrotic syndrome. I didn't put that in here because I only saw that in one textbook, but I'm just putting that out there. Hypoalbuminemia, hyperlipidemia, and hypercoagulability, again, are all part of the collection of presentation of nephrotic syndrome. The official diagnosis is done by proteinuria. That's over 3.5 grams a day. That's if we're measuring a full 24-hour urine, and by a kidney biopsy. Again, just like the one before, this kidney biopsy is going to be the standard in order to guide our treatment. The management is going to be treat the underlying disease. If it's because of the diabetic nephropathy, treat that. We mentioned lupus just a minute ago. If that's the problem, treat that in order to get rid of the nephrotic syndrome. These patients will probably need dietary modifications in the recovery process and in the acute setting. And that's going to include low sodium and moderate to low protein diet to manage their edema and their protein loss. These patients might need a little bit more protein than most of our nephrology patients because of how much protein they're losing. But still, we're not going to put them on a high protein diet. Medications, we might give them ACEs and ARBs because, again, we said this is associated with a number of different diseases that can be helped by that. We might give them diuretics. We might give them statins. We might give them anticoagulants. Again, you should be recognizing that the anticoagulants is because they have hypercoagulability. The statins is because they have hyperlipidemia. The diuretics is because they have edema, etc. Next, let's talk about diabetic nephropathy and diabetic kidney disease. Again, we're just doing a brief overview over here. Diabetic nephropathy or diabetic kidney disease is chronic hyperglycemia leading to damage of the glomeruli and renal microvasculature. This is the disease that ends up in chronic kidney disease. So patients who have diabetes, who don't manage it, they're going to get diagnosed with this, and they may have this for a day, they may have this for 30 years, depending how well they manage their diabetes. But if they don't manage this well, once they have this diagnosis, they are going to end up in chronic kidney disease. And like we said, chronic kidney disease, if not managed, will end up with end-stage renal disease. So let's go through the patho. Chronic hyperglycemia is going to lead to damage of the glomeruli and the renal microvasculature. How does this present? Usually asymptomatic. We usually catch this because we're monitoring for it in a patient that has diabetes, more so uncontrolled diabetes. This will progress to proteinuria, albuminuria, hypertension, and edema. We're going to keep an eye on all of those in any patient that has diabetes. This is diagnosed by an elevated BUN creatinine, a low GFR, which those always go hand in hand, a high BUN creatinine, low GFR, a high A1C, that's the sugar, the diabetes marker, and albuminuria, elevation of the albumin above the 300 per day. A normal albumin is less than 30. 30 to 300 is albuminuria. This is where we'd be even on the higher end to 300 plus, but anything above 30 is abnormal. Next, management of this is to address the underlying cause. Once again, focus on that diabetes. Diabetes left uncontrolled is just going to kill the kidneys, literally, figuratively, in every way. Or also manage their underlying hypertension if they have it, and their underlying hyperlipidemia if they have it. So again, if a test asks you what nephrology patient would need to be on an antihypertensive or an antihyperlipidemia, this one could be a correct answer. Recommend low protein and low salt diet, again, because we're trying to reduce the workload of the kidneys because they're not doing well. This is where the majority of the patients with CKD started from. They started with this diabetic kidney disease. Finally, we end up where the last thing we're talking about is polycystic kidney disease. The pathophysiology here is this is a genetic disorder. It may present in adulthood or childhood or when you're an infant. And this is a genetic disorder with growth of multiple fluid-filled cysts in the kidneys. These leads to progressive enlargement and loss of kidney function, enlargement of the cyst and loss of kidney function. There's two types. There's adult polycystic disease and infantile polycystic disease. Obviously, adult would present in your adulthood. I think this one's around 30 to 40 years old is most common versus the infantile one. The cyst will interfere with normal kidney function as well as the normal structure of the kidney as well. So we could see this when we're looking at the kidneys with imaging. This can cause hypertension, kidney failure, and other complications. The presentation of this one will be flank and abdominal pain, hematuria, that's blood in the urine, hypertension, and recurrent UTIs. This is diagnosed by renal ultrasound. Again, we could just see the cysts right there. The management depends on what's going on. If the patient is having high blood pressure because of it, like we just said, hypertension, then we're going to control their BP. We're also going to put them on a low sodium diet, like pretty much all kidney patients. If they're having recurrent UTIs, we're going to treat the UTIs. We're also going to increase their fluid intake unless they're heading towards ESRD.